this is the fourth Advanced Pediatric Endocrine Symposium, which we are organizing. The first one in the form was actually started off in 2017. And since then, many of the faculty, all the guiders, everybody is the same. And we are continuing with the same team for quite a long time. It's been really a pleasure in that regards. Now, when we had initially, we were always thinking that pediatric endocrinology is a rare group of disorders, which are complicated, which are cumbersome in terms of workup and very expensive treatment. So people used to, in a way, shrug away from pediatric endocrinology, don't want to go into this field, and everybody was very scared, so to speak, about that. Now, when we thought about this, what we realized that there are three issues in any health problem: awareness, accessibility, and affordability. Now, everybody says these are not affordable, but we believe that awareness actually is the elephant in the house. And if we increase the awareness amongst the general public, amongst the physicians, we would be able to improvise the care. And this was the motto by which we established the pediatric endocrine group, and then we started the Growth Society working in that direction. Now, if you look at the pediatric endocrinology burden in India and the specialists who are available, what we see is that we would probably have a handful, maybe 100 will be the overall, maybe an overestimation also at the moment, but now with more fellows, the numbers will increase. So this still is a very, very small number for the burden of population for type 1 diabetes, growth hormone, thyroid, all those things. And pediatricians are approximately in much bigger numbers. So we need to really have a bridge in which things can improvise and connect between the two so that we can have a continual good quality care in everywhere. So currently pediatric endocrinology is focused and centered in few cities. Some cities like Bangalore will have maybe 20 people who are there, but then some whole states will not have people who are trained at all. So we need to have more wider exposure, and that's why it's very important on part of everybody. And it's responsibility of us pediatric endocrinologists, and ISPE has been working a lot in that to really spread the message of pediatric endocrinology. We have been doing a lot of programs right from 2011, and you can see many of the same people have been involved, and they have always been our inspirational force there. We started with our first program in 2011, and then since then there have been hundreds of programs which were done in terms of workshops, in terms of advanced courses, practical courses across the country, which we have been conducting. Now, this basically is the third Advanced Pediatric Endocrinology Symposium. And from there, what we realize that if we keep on doing workshops, how much time can we spend? Like, it's not possible to do workshop everywhere. So we started off with social media in terms of YouTube platforms. And from there, a large number of people actually were able to access, and you don't need to be there all the time. They can access that. Then we started an on-site fellowship program, and we have got Chetan from the first batch, Neha from the second batch today, who are there. We until now had 11 fellows who are being under part of training. Then what we realized is that if you want to have a structured training, we need to have a web-based program. So we started with our MedEClasses platform, which provides a lot of information, started with books, and then to practically use that knowledge, mobile applications were developed. So we have got a lot of e-learning videos available on YouTube with huge number of views. This is something which is available covering entirety of pediatric endocrinology. We have got structured learning program under our learning.growsociety.in. We also offer a 2-year hybrid program for fellowship and a 1-year hybrid for diploma. We had got a lot of people who come to us every 6 months for a week. They learn the exam. So it's a very intense process. So we are going to have some of the announcements about the results of the fellowship program, the first one. We conduct a lot of online courses, pretty much 3 to 4 every month. So it's quite intense. We have got a number of publications which are there. And what we are going to launch today is the second edition of our pediatric endocrinology protocols, which is a completely updated book about latest protocols for pediatricians, pediatric endocrinologists, and we'll be releasing this today. One major advantage we wanted to take was with regards to our application, because that will provide much easy access to use, because what you learn, if you don't use it immediately, you will forget and the errors will come in. And these applications were developed, and they are now become the most popular endocrinology application across the globe. And we have done a lot of publications regarding the growth interpreter, which allows practical interpretation of growth. We have got the obesity interpreter, which has been validated. We have got puberty interpreter, which allows interpretation of puberty, for thyroid, for DSD, and all of them have been presented and they are in publication in different places in that regards. Now, what we have done now is a very interesting thing, which is actually a combination of all that we have done. This is a bone age assisted interpretation of growth. So all the pediatrician would have to do is to put some basic data. It includes information like birth weight, sitting height. So all the rough things that we anyway write down and we measure, we just write the Tanner staging, we match it, we have the bone age interpretation. And as soon as this is done, it is using all the algorithms which are available. And based upon this algorithm, we will have a lot of information, data points will be available. So you will have specific charts, bone age interpretation, lot of parameters, and this will predict the likely diagnosis, most likely investigation. And we are validating this now. So this will be a very valuable tool for screening pediatric endocrine disorders. And hopefully, so this is how the result will look like. So you will have charts and you will have table which has got a lot of interpretation, and then we'll give you the final interpretation as to what is the likely diagnosis in that regards. We are coming up also with a personalized intelligent EMR, which is going to basically decide based upon specific conditions, give the inputs for every condition. And once you choose those conditions, you get the data, you will get an output which will guide in terms of evaluation, assessment. So only those which are relevant will come up on that drop-down menu. And based upon that, you will have a state-of-the-art evidence-based algorithm-driven approach which will come and analysis will come. This will provide information in the form of also a nutrition chart. So a 7-day meal plan will be there. So we had got, recently we had this on-site course in which we had got large number of people who had come from across the country, and we had around 200 patients who were seen over the last 3 days. And we had a very intense discussion which was there. So this Advanced Pediatric Endocrine Symposium, we're going to cover a lot of aspects of pediatric endocrinology, how common problems which are seen in pediatric endocrinology, and how we can easily make it more comprehensive and more regarding that. So why is endocrine diagnostics very, very important? Is that these are our entire diagnostics and therapeutics is dependent upon what these tests tell us. So these hormone assays are really vital. They are really a game changer because your decision will be based upon that. Although they often are considered to be complicated and confusing. And because if you don't interpret these results properly, you will have huge implications in terms of evaluation and management. So you need tests which are precise, which are accurate, sensitive, and specific. And that is what we want to look at. Now, why are these tests so difficult? Now, we are dealing with large molecules. When you're measuring sodium, potassium, they're very small molecules. We're talking about big peptides which are there. We are talking about ranges which are huge. So you can have a TSH of 0.4 to 4, at least 10 times is normal. Prolactin even longer. So you have a huge range of these assays which are there. Puberty can change. So levels in a 10-year-old boy of LH will be different, 14 years will be different, 18 years will be different, and 80-year-old will be different. So you need to interpret in light of puberty and a lot of variations which are there, which make it very, very difficult in that perspective. So when you write a prescription and by the time you get the report, there are a lot of errors which may happen. Errors may happen in the test that you have said, in the timing of the test, in the sample type that you have advised, in the way those samples were processed, and the way those tests were done. So there's so many errors. So as they say, lot can happen by the time you take the cup and take the sip. A lot of changes can happen and a lot of errors can happen in that regards. So if we look at overall, we can have pre-analytical error, which basically mean that pre-analytical error would basically mean that you have not even done the test and you have got errors. So this is important. Then the test can be erroneous and how you interpret the test. The most important part of the stethoscope is in between the ears. So most important part of an endocrine report is what you are analyzing also becomes important. Now 50% of errors can be pre-analytical, wrong time, wrong sample, wrong tubing, label, all those things. 30% are analytical. So your lab did a difficulty. So you need to be careful in terms of lab. And 20% can be post-analytical. So you have interpreted it wrongly. So these all we will be discussing about. So now why do we commonly do an endocrine test, Dr. Vibha?
So generally we do endocrine tests for the screening purpose to make the diagnosis. And if by making the diagnosis, we can change our treatment plan. So these are the main recommendations that we do for this endocrine
So
test.
we need to have different types of tests. When we talk about a screening strategy like congenital hypothyroidism, we need different tests for diagnosing that hypothyroidism. And when you're monitoring, you will have a different strategy. So I think these three becomes important. So don't order a test in everybody. Only if it is going to change your management, then only you should write a particular test in that regard. So we can start off with the cases. You can move this.
Thank you, sir. We have this 10-year-old boy who came to us with a growth failure. He has a short height of 127 centimeter and weight was much affected. It was minus 4.8 standard deviation below. And his normal screening workup was all normal, but his IGF-1 level was low. So some physician has done the growth stimulation test and it came out to be normal. So kindly advise me, sir, why this is discrepancy between this growth hormone stimulation test and this low IGF-1 value.
So I think that's a very, very important point. So whenever you are evaluating anybody, you need to think about which test is important to choose. Now, this child, what you look at, first of all, look at the growth chart. If you interpret the growth chart, you will see that his weight is much more affected as compared to the height. So I don't think of an endocrine cause. I'm thinking more like a nutritional cause. Now, in this scenario, the IGF-1 level is low. Now, what are the two factors on which IGF-1 depends? Maybe the audience can say out loud. Nutrition as well as liver function. So if you are malnourished, your IGF-1 will be low. So this IGF-1 has got no value. If at all you wanted to do a growth hormone, you could have done that, but I would be wary about that. So again, this is a wrong test. So in a malnourished child, in a child who is less than 5 years of age, in a child who has hepatic disease, do not do a IGF-1. I think that's something which is very, very important. So the test to order will depend upon different scenarios. So we can order either the whole hormones. So often like thyroid, cortisol, we order the whole test. Sometimes these hormones are very short-living. So they will be destroyed in the plasma. So what are the examples there, Vibha?
So the hormones like peptides, thyroxine.
So short-living will be like insulin. Like AVP. So in these scenario, you will take co-secretor. So if you look at insulin, you will use C-peptide as a marker, which is a longer half-life, or co-peptin for AVP. Then sometimes we look at effect. What is the calcium level? What is the ketone level? That will give you a clue. Now, one example is hyperinsulinism. So insulin measurement is very difficult. So better to look at ketone, which will give you a much bigger picture in that regards. And sometimes we do a metabolite evaluation in that regards.
Thank you, sir. So we have this now 15-year-old boy who came to us with obesity. He had a hypertension, and as we can see in the picture, he has abdominal stria as well. He has hypertension, and it was 140/90. When we did the overnight suppression test, the cortisol level was suppressed. So I thought to do the serum ACTH level, and it was high. And then MRI was done, and it turned out to be normal. So I was thinking I should do another test to look out for the ectopic Cushing. So do you agree with me, sir?
I think the main issue is that why are you doing the test? You should understand. Now, when you talk about Cushing syndrome, there are screening tests. That this test is to just screen whether Cushings are there or not. That is an overnight dexamethasone suppression test. Then you have got a confirmatory test, like a low-dose dexamethasone suppression test. Then you have a classification test like ACTH. Now, if you look at your first test, your overnight dexamethasone suppression test is already suppressed. So you have excluded Cushing syndrome. So now doing a ACTH will be of no role. So I would not be even thinking of a Cushing syndrome. So why do a ACTH? Second, which type of sample you have taken is important. So here you have done a serum ACTH. So serum ACTH should not be done. We do ACTH in the plasma. So this is something important. So if you take the wrong sample, then the machine will give the wrong result. So if you have a garbage in, you will have a garbage out. So you need to have a proper way in which you have done the sampling. So we know there are various types of sample. Whole blood is not used in most cases, only for those which are very metabolically active. So example will be blood glucose. We do the blood glucose. Otherwise, why will you do a point of care test, HbA1c? You can do that. Now, once you remove their blood cells, it becomes basically a plasma. So plasma also is a very labile substance. This is also not used very commonly. You will use for dynamic changes. I think ACTH will be one in which you will use plasma as we discussed. For all other, once you remove the clotting protein, it becomes basically the serum. And for serum, you have much stable levels and you will use it for most situations. You will use serum, but which sample to choose becomes absolutely important. You can also think of urine collection, but that becomes difficult in children because of a 24-hour collection and you have to correct it for creatinine. And you can think of saliva. Where do we use saliva for?
So we use saliva when we want to free cortisol levels.
So mainly for cortisol, and saliva is a filtered. It's like a free cortisol. So it's mainly for Cushing syndrome where you will be using this.
Thank you, sir. We have this 11-year-old boy who presented with growth failure. He was really short. He was minus 5.4 standard deviation and he has immature facies. His all other screening tests were normal and he was looking growth hormone deficiency to me. So I did the basal growth hormone level. It also came out to be low. So could I start the growth hormone therapy in this child on the basis of this?
So do you all agree that just because of basal growth hormone, will you start growth hormone? I think everybody is saying no. The reason is that growth hormone is a pulsatile hormone. You have only few pulses of growth hormone. In between the levels may be zero. It is of no consequence at all. So we need to consider when you're ordering a test, what type of variation happened with that hormone. So if you look at growth hormone, you can have a pulsatile hormone. And a lot of these hormones like prolactin, LH, FSH, they have a pulsatility. So either you do a stimulation test like growth hormone stimulation test, or you do a pooled sample. Now, what do you mean by a pooled sample, Vibha?
So we take samples and then we collect all together and we take out the average value of each sample.
Yeah. So what we do is that we take 3 samples, 0, 15 and 30 minutes, and we mix all of them and then measure. So you don't need to do it 3 times. Some people ask me that whether you do it 0, 15 and 30 and then average, which what you are meaning by average is that you will pool all of them. So single report will be done, not 3 times, but the pooling will be done. Now you can have diurnal variation, and this is the classical graph for cortisol. So cortisol levels are highest in the morning. So if you're looking for deficiency, do in the morning. They are lowest at midnight. If you're looking for excess, do it at midnight. So I think this is something which is there. Then you can have the periodic variation like menstrual cycle variation for LH, FSH, for progesterone, 17-OHP, which is there. And some of them can have seasonal variations like vitamin D, thyroid and estradiol. So you need to know what variations are there and then do the test accordingly. So if you have a pulsatile hormone, now Vibha, what all can you do in this case?
So in case of pulsatility, as you have said, we can take the pooled sample.
Yeah.
And we can do that stimulation that as we do in the growth hormone stimulation.
So you can either do a pooled sample or you can do some things like a timed one, like cortisol you do in the morning. That's most likely. You do a co-secretory products like copeptin or C-peptide, or most commonly we do a dynamic test. Now, if you think of endocrinology, it's very simple. If you're thinking of excess, you suppress it. So do a suppression test. Dexamethasone suppression test is a classical example. If you have deficiency, you stimulate. Growth hormone deficiency, you have got GnRH stimulation test. So stimulation and inhibitory test will be the ones which we'll look at.
We have this 13-year-old boy who came to us with weakness and lethargy. He had pigmentation also. His electrolyte profile shows normal sodium and normal potassium. So we did the cortisol level and it came out to be, we did the random cortisol, in fact, and it came out to be low. So it is looking like cortisol deficiency to me because he had the symptoms of weakness and pigmentation. So, sir, do you agree with me? Is it cortisol deficiency?
I think a very important message in endocrinology is always to think of contextual assessment. So you have to see in what context this cortisol level is. Single low cortisol level is absolutely of no value unless you have got associated conditions where cortisol should have been high. So if you had hyponatremia, if you had hypoglycemia, if you had shock, then this cortisol will be very, very important. But otherwise, single value I will be very, very varied. There is another condition, if your ACTH is very high and still your cortisol is low, you are pigmented. So maybe you can do a ACTH. If ACTH is more than 200, I would think this becomes significant. So this again is not going to be very important, and the timing also becomes important. So whether you did it what time. So 8 AM value in this case was normal again. So identify. So this was a wrong timing. So these are all pre-analytical issues we are talking. This is not the error of the lab. You don't have a right to say the lab, okay, you have spoiled my test. This is our own errors that we are doing, which we want to avoid. So now if we talk about diurnal variation, as I talked last time, that if you're looking at deficiency for cortisol, do it in the morning. If you're looking at excess, do it in the midnight. That is what is recommended from that perspective. And there are other tests you can do for diurnal rhythm and DEXA suppression test, which we discussed.
We have this 15-year-old girl who visited us for increased facial hair growth, menstrual irregularity, and when we examined her, we found her pheromone Galvez score was 12, which is mild to moderate. And when we show her hormonal profile, LH was high, FSH was mildly elevated. So when I saw this report, it was looking like a case of hypoandrogenesis to me. So I decided to start the E+P preparations. So, sir, do you agree with me? Should I start?
I think, yeah. So we have to be very, very cautious in this regards. The key question I will ask is, what time did you do the LH-FSH level? Because we know that if you talk about the menstrual cycle, in the initial phase, FSH and LH will be 0. They will start rising. FSH will remain higher than LH throughout the cycle, except for around day 14 when you're at the peak. So whether it is in the proliferative phase or it is in the secretory phase, whether it's in the luteal phase or whether it is in the initial phase, that's what will be very, very important. So when was this sample actually taken? It was
done like in the post-ovulatory phase.
Post-ovulatory phase. So ovulation, and that time your LH will be very high. So anyway, LH-FSH is not a very good marker, so to speak, of PCOS. And we know that high LH is an effect of PCOS and not the cause of PCOS. Here, of course, you should do it on day 2 of periods. And when we repeated, it was found to be normal. So again, all these things that we discussed have become very, very important. So again, this was a wrong timing, which we saw here. So if you have a cyclical variation, best is to do it according to a particular time. If you're looking at LH, if you're looking at FSH, if you're looking at testosterone, if you're looking at 17-OHP, day 2 to 4 will be the best. If you're looking at progesterone, what will be the best time?
Day 21.
Day 21, because that's the time when the luteal phase is already established and you will be able to get the idea from there.
Thank you, sir, for enlightening me. We have this 6-month-old girl who was referred to us with seizures, and she had low calcium and low phosphorus level also.
So what does the audience think of this case? Hypocalcemia and hypophosphatemia. So you've got low calcium, low phosphorus. Is it PTH or is it vitamin D? Vitamin D. I think everybody is agreeing. So the most important investigation in a case of hypocalcemia is phosphorus. If your phosphorus is low, you're thinking of vitamin D. Now, what are the results we got?
But in every case of hypocalcemia, we generally do the PTH level to see whether there is a case of secondary hyperparathyroidism or not. But when we get the result of PTH level, it came out to be low. And as you all said, the vitamin D level was low. So what is this confusing scenario? Why the
now the question is whether the egg came first or the chicken came first, the PTH, the calcium, all those things. So now I would say, what do you expect with a low PTH? What is more likely?
Sir, with low PTH, the phosphate level should be high.
So it is extremely unlikely that you have got a very low phosphorus and yet your PTH level is low. And we know which is a more robust test, vitamin D, maybe the audience can tell us, or PTH, which is less likely to be affected by the problems of assays. Vitamin D is definitely going to be much less likely to be affected. And PTH, we all know, is a very labile hormone. Often we see that PTH is sent to a collection center and they will keep it there. The time it gives the lab is like a day or two. And by that time, the PTH would be lost because PTH has to be done immediately or frozen. So the problem that is there probably is that your PTH assessment was probably inaccurate. And when we did in our own in-house assay, it was found to be normal in that regard. So this was an incorrect storage.
Thank you, sir. So,
yeah, maybe we can give the mic to. The PTH was high because the vitamin D was low. PTH is intact PTH. So when we talked about PTH, there are various generation assays which are there. intact PTH is the one which is basically looking at different segments of the PTH. Earlier, people used to say N-terminal, C-terminal. Now, intact PTH has got two segments they are looking at. This is the best test as far as PTH is concerned.
So we got this reference from the NIC for this 20-day-old girl who was having seizures. She had a sort of hypoglycemia. She had a blood sugar of 22, and she was maintaining blood sugar on the GIR rate of 12, which is quite high. The hypoglycemia was non-ketotic, and the cortisol level was within the range for this level of hypoglycemia.
So now I think the audience can pitch in that we have got a child who has refractory hypoglycemia and the ketone is negative. What is the most likely diagnosis? Hyperinsulinism. So like we said, phosphorus is the most important test in hypocalcemia. Ketone is the most important test in hypoglycemia. So now we all expect that insulin will be sky high. Now, what's the result here?
I expected the insulin level to be high, but what I got, the insulin level was undetectable.
So can you biologically explain this scenario, Vibha?
Yeah, definitely, sir. It could be due to the transport or the
No, I am saying that can it be really true that if you did it properly, can you have a situation?
Sir, if the patient is requiring so much high GIR and this is non-ketotic, so definitely we have only one possibility left, that is the
this is increased insulin effect. Now, theoretically, I can say, okay, you can have a post-receptor problem, activating mutation in the AKT2 pathway, which can cause that, but that's only 1 or 2 case reports have been reported. So before I go to rare condition, I will directly go to whether the insulin was done properly or not. That is also important. So insulin and PTH are two hormones. Whenever I get the report, I want to be very sure whether it was done properly or not. So when we look at, this was again an issue of sample instability. So whenever you are sending these things, either you send the person to that particular lab which is doing it, or you ensure that the person comes to you with an ice pack and they have got all the frozen facility. Otherwise, the results will be very, very variable and you will not get the right result. So normally we say that things like ACTH, PTH, insulin and renin, these are the ones which you want to be frozen. Otherwise, results will become abnormal. Now, renin is basically an enzyme activity. So of course, you require a frozen one. But never freeze AVP because that will cause a problem. IGF-1 should also not be frozen. And things which are not affected by temperature are like common things like growth hormone, cortisol, vitamin D, LH, FSH. These you can send it as you wish and they can be stable for a long time.
Thank you, sir. We have this 7-year-old girl who visited our OPD for early puberty. She had a breast test of 3 and a pubic hair of 2. When we did the bone age examination, it was advanced, it was 10 years. And when we did the hormonal profile, even the LH-FSH ratio was high for his age. But what we got is her estradiol level was low, which was not fitting in the scenario.
So do you think the audience that this child has early puberty? At 7 years of age, breast is 3. So we talk about slowly progressive and whatever, that's breast 2 usually. The bone age is 3 years advanced. Yes. So this is definitely a early puberty. And what you're seeing, LH and FSH, both levels are high. And we say LH is the most important test to identify precocious puberty. Now the treating physician is saying estradiol is 0. So why do we need to give any GnRH analog? So the problem, what do you think would be a problem, Vibha, here as far as the estrogen reports are concerned?
So for this estrogen report, I would say it would be regarding the type of assay we are using. Because generally the assays that is used for the measurement of estradiol is prepared for the estimation of high values of estrogen. And but in this 7-year-old girl, the estrogen level will be like around 25, 26. So due to the improper use of assay, this could have been.
So this is a very, very valid point because we need to understand what is the purpose of that assay. The estradiol level is done for reproductive age group, levels of 80, 100, 200. When you have a level of 10, 20, it will do a wrong result. Similarly, we always say glucometers are there for hyperglycemia. When you have hypoglycemia, you confirm it on a lab sample. So this becomes very, very important. So technique is also very, very crucial. So we always commonly use immunoassay, which is an easily available technique, a technique which provides us with immediate result. But this technique has a problem because it can have a lot of overlap. It has a larger molecule, larger volume is required, and peptide will be the one which are preferred. It's not a very good for a steroid molecule like estradiol or cortisol. You may not get a good result, or testosterone. Now, the one which we'll prefer in those scenarios will be a mass spectroscopy, which depends upon the mass and charge ratio. So it has got more specificity. It's good for smaller molecule. You need very small amount of blood, and it is good for steroids. The problem with this, it's more expensive. So whenever you do precocious puberty, I would not even look at estradiol. Yesterday, we were discussing so many cases in which estradiol was discrepant. So don't worry too much about estradiol. The only role of estradiol will be when it is more than 100. So what condition will have estradiol more than 100?
So the peripheral precocious puberty.
So if you have estradiol more than 100, there is an ovarian cyst. Basically, that's it. Otherwise, I would not look at estradiol. Look at LH, which is a more important marker for precocious puberty. So what now, once you have done, we talked about the pre-analytical issue. The next issue is about what we want from the assay. We want from the assay that it gives us a true value, which is basically the accuracy. We want that it is reliable. Every time you do, you get the same result, basically. You don't get other results. So if you want cortisol, you get cortisol and not cortisone. That becomes important. You have a wide range, so sensitivity becomes more. You need to be stability in terms of sample, and you want a good interpretation in that regard. So these are the requirements which are there. And accuracy, basically, all labs have to maintain their accuracy. They compare to gold standard. If the lab is not doing that, you have to really question them. So you can ask, when was your last external standard done? And this is done using a Uden's curve, which you don't need to understand, but you need to ask them that whether they have a good NABH accredited laboratory. NABL accredited will be requiring to do all that things.
So we have this 12-year-old boy who was a diagnosed case of 21-hydroxylase deficiency. And he was on hydrocortisone dose of 15 milligram per meter square per day. And when on the follow-up, we did the 17 OHP level, it came out to be 4 nanogram per ml, which is a little bit high because we use the cutoff 3 nanogram per ml. And when we repeated the sample, it decreases down to 2.4 nanogram per ml. So with this 2.4 nanogram per ml, should I have to decrease the dose? Or
I think this is something you need to understand, that when you do the same assay twice, there will always be variability which is there. Often people say that this glucometer is not very good. I do it after 2 hours, it becomes 10. So there is a biological variability. Your sugars may have changed. Similarly, the machine already has got a coefficient of variation. So all this value of 4 and 2.4 is same for me. I would not be too much bothered. You need to know what is the CV, or coefficient of variation. So what is coefficient of variation, Vibha?
So coefficient of variation is a standard deviation upon mean, because we see how much the values is deviated from the mean.
So it gives us an idea about how accurate is your test. In a way, how precise, rather not than accurate, how precise is your test. If you repeat it every time, how much variation you will get. So every lab is supposed to maintain a LJ graph like this. If you have this sort of a pattern, which means your values both up and down, this means that there is a random error. This is not a systematic error. So this is both accurate and precise. What about this? What do you see here, Vibha?
So this is deviated towards the down. This is not accurate.
So this is a systematic error which you are seeing here. So this is definitely a inaccurate one. And then you have got huge variation. So it's a both random errors which are there. So we prefer the first line, which will be the best one in this regards. So as discussed, coefficient of variation is standard deviation upon mean. It should be quite low. If it's more than 10%, we start to get worried about in that regards. And we also take into account the biological variability, which is there. Now, very importantly, you often get these reference ranges. Now, how do you get the reference ranges? So one way is that this machine can measure from 0.1 to 100. So I'll say the range is 0.1 to 100. But what you need to understand is that the accuracy of that particular assay is going to be different at different levels. So what you're seeing here is this is a CV on this y-axis, and you've got the concentration. So it is good for the intermediate concentration. But at lower concentration and higher concentration, it gives you a huge amount of variation. So we set a limit. If it is more than 20%, I would not be using this range. So your reference range should be within 20% of variation. That's the range is the best in terms of outcome.
We have this 10-year-old girl who was a diagnosed case of acquired hypothyroidism. She's well maintaining of thyroxine of 100 microgram. On follow-up, she came with a TSH report of 54. According to her, she has a good compliance and she has no symptoms of hypothyroid like constipation, hair fall. But this high TSH is not correlating with his symptoms. So we repeated the TSH with other lab and it came out to be 2.5. So, sir, why is there discrepancy between the two labs on the TSH values?
So I said there can be a biological variability, which is there. There could be assay variability, but this is huge. It's like 20 times. So when you have a discordant result, ask them to run it again because there is something called what is known as a carryover effect. Suppose the sample before this was done on somebody whose TSH was 1000. So there will be some amount of that sample which is carried over to the next one. So ideally, your lab, if it's good, they should have a very robust washout technique. They will remove all that, but sometimes you can have a carryover effect. So if you have completely discrepant report, tell the reason and ask them to repeat it, and then maybe you will get the right report on that setting. Biological variability means I will have a TSH of 4 today, and tomorrow it may be 4.4. Because it will depend upon temperature, it will depend upon what my mood are, whether I'm exercising or not. Similarly, like sugar, your sugar may be 99 and then 104, then 84. So it's always going to change. Temperature will change. So all this variability will be there. So this is biological variability. What we want is the analytical variability to less than biological variability. If your analytical variability is more than biological variability, your results will going to be very much abnormal.
So next case, we have the 16-year-old girl who presented with the complaint of galactorrhea. She also showed her hormone profile reports and the prolactin level was 16 only. She also gave a history of headache and vomiting along with headache. And so we get the MRI done. The MRI showed a large adenoma in the pituitary. So why this the prolactin level is so low and the MRI showed a large adenoma. So is this really a pituitary adenoma or something else on the pituitary scan?
I think this is a very, very important phenomena to understand. Now, why I'm looking at clinical parameters. She has galactorrhea. So now if you have galactorrhea, you have to think of that prolactin level definitely has to be high. Now you also have a CNS lesion, a pituitary adenoma, which is classical adenoma. So I would expect the prolactin to be above 100 and very, very high. Now, in certain scenarios, especially with the older assays, if your prolactin level is very high, like thousands, you can get what is known as a hook effect, in which as the levels go a particular high, you will have paradoxically a low level of prolactin. So this is a scenario, what is known as a hook effect. So in this scenario, you should do a diluted sample, and on that you will get the right result. So I think if there is a clinical discrepancy, think of this hook effect, and the other is macroprolactin, which can sometimes happen. This will happen with other things as well, like HCG, TSH, and calcitonin.
Thank you, sir. We have this 17-year-old girl who was a follow-up case of papillary carcinoma of thyroid. She had undergone surgery as well as the radioablative iodine ablation. So on the follow-up, we did the thyroglobulin level to see is there any residual disease present or not. But the thyroglobulin level was undetectable. And when the radioactive scan was done, it shows a lesion. So whether this scan report is reliable or we should repeat this thyroglobulin level.
This is a very, very important clinical scenario. When you have somebody with papillary carcinoma, differentiated carcinoma of thyroid, you are really looking at whether the lesion is coming back again or not. And one way of screening is thyroglobulin. So thyroglobulin is only produced via thyrocytes. If your thyroglobulin is becoming high, it means that your recurrence is happening, and then scan will pick it up. However, here what you're seeing is thyroglobulin is 0 and scan shows a lesion. So what does it mean? It means there may be an error on the thyroglobulin assessment. And what we need to remember is that it may be associated with antibodies. So sometimes you may have antibodies which will interfere with the results. And this is going to cause a falsely low picture on a non-competitive assay. So you can use a GCMS based technique to get a better thing, or better do an anti-thyroid globulin every time. If your antibody is positive, you need to be worried about this.
We have this 11-year-old boy who presented with lethargy. He had a free T4 level, which is 3.2, which is low, and the normal TSH of 3.4. And
so what does it mean? If your free T4 is low and TSH is less than 20, we have
central.
It looks like a central hypothyroidism. So now you have to think of MRI, you have to think of cortisol, you have to think of all the other anterior pituitary functions.
But he had no goiter and the TPO antibody was negative. When we again repeated the result, the T3 and the T4 reports came out to be normal. So how is it possible? Like how the result
so
came
I
normal?
think we need to be very cautious in the free T4 assay, because free T4 assay is affected by a number of factors. An important one of them also can be some of the heterophile antibodies. So when we say heterophile antibodies, these are antibodies against the animal tissues, which can cause confusion in terms of assessment. And you can have falsely low or falsely high levels, which will be there. Now, they can cause both high level and low level. So in this rate, you do it on a different platform and you will get the right result. What is the platform in terms of lab?
We can repeat it on the different lab.
On a different lab. So platform means that you're using a different reagent, basically. So there, the antibodies will not have an effect. So this becomes important. So different lab will give you the right result. So again, there are a lot of reasons for erroneous results, which can be in the form of interference or the binding proteins, which can have a different samples or effects, which will be there. So you have to ask the lab if your results are not fitting in, they will have to reassess and evaluate from that regards.
We have this 14-year-old boy who presented with gynecomastia. The breast enlargement was around 10 stage 2. The testicular volume was 12 and he has a pubic hair of grade 3. The LH level was 1.8 and the testosterone level was 120 nanogram. And when the prolactin level was done, it was high. It was 120. So, whether this prolactin is causing this gynecomastia? So, considering this high prolactin, we did the MRI head and it came out to be normal. So, why this high prolactin and normal MRI and this gyneco, all this picture is looking very confusing to me. So, kindly explain.
So, now if you're looking in this picture, what we are seeing is that your prolactin is high, but your testosterone is good for this age. Now, why does hyperprolactinemia cause gynecomastia? It is through hypogonadism. So if you have a normal testosterone, it's unlikely that this hyperprolactinemia is significant. And hyperprolactinemia is not a cause of gynecomastia directly. So I will be very wary of this prolactin. We talked about a hook effect in which if the level is high, you are saying it as low. This is the other scenario in which you can have a macroprolactin, in which if the levels are low, your levels are high, you actually don't have a hyperprolactinemia. It's a non-functional prolactin in this regard. So what you do here is do a pegylated sample and you will get the right result in this perspective.
Thank you, sir. Now this 14-year-old boy who came with a delayed puberty, when we examined the child, he has a pubic hair 1 and testicular volume of 4 ml. His testosterone level was undetectable. So we repeated the testosterone level and it came out to be 24 nanogram per ml. So, sir, how should we interpret this?
Again, this is an issue about the coefficient of variation. Now, we say that 20 is the level which you detect. Now, if it's plus minus 4, it may be 16 or 24. If it is 16, you will say undetectable. If you say 24, it becomes detectable. So this clearly does not mean that there is a huge variation, but think when you're looking at that assay. What will be more important for me in this case? What is a better marker of pubertal onset in this case than testosterone? Is the testicular volume. He has a 4 testicular volume, so he is entering into puberty. Don't get too worried in that regards. So we need to understand that sensitivity of a test will vary, and therefore you may falsely say that this is undetectable if your sensitivity is a bit high. When we say sensitivity, this is analytical sensitivity, the lowest your assay can measure in that regards. So this becomes important and significant from that perspective. So this is already, we said that you have to set it according to the coefficient of variation where you get the right result.
So we have this 8-year-old girl who presented with short stature, and we measured the height. The height was 128 centimeter, which is just minus 1.5 standard deviation below. Her weight was 28 kg, and all the screening tests were normal. So somebody did the growth hormone stimulation test, and the growth hormone level shows 9.2, which is in the partial growth hormone deficiency. So should we treat this child?
Now, the first question is, do you think this child has DHD? Height is only minus 1.5 SDS. So whenever we say when do you do a growth hormone stimulation? When the height is very short, less than -3 standard deviation score, -2 to -3 and less growth velocity. These are the conditions. So your pretest probability is very less. So don't order an endocrine test if you don't think it will be positive. Otherwise, you will get confusion. Now we don't consider 9.2 as low. It is 7 is considered a cutoff, but some people still consider 5 to 10 as partial. So this will cause confusion. So this is low pretest probability. Now I'll just give you an example how the prevalence of the disease or the pretest probability determines the diagnostic accuracy of a test. Now, if you say that you've got 200 people, 50% have affected, or in a way you can say, I have a 50% chance that this child will have GHD. You have a sensitivity of 90, specificity of 90. There your positive predictive value is 90%. So your positive test, 90 out of 100 would become GHD, and your likelihood ratio is high. Now, suppose your probability becomes less. It's only 10%. 10% is the prevalence. The same sensitivity and specificity, your values will become much less. Your positive predictive value becomes 50%. Now, what it means is that in the first scenario, 90 out of 100 positive tests will be positive. Here only 50 will be there. So if you have less possibility, do not do the test. That is the key message that is there, which we like to give. And this is what is shown is that the prevalence of disease will decide about the positive and the negative predictive value, which are the most important parameters to follow in that regards.
So again, we have this 12-year-old boy come with the delayed puberty concern. He had a testicular volume of only 2 ml and pubic hair of stage 1. He has a bone age which is delayed by 2 years, and this LH, FSH, and testosterone all were low for his age. Then the MRI head was decided to do, and it came out to be normal. So why this is looking like hypogonadotropic hypogonadism to me? So why this? How should we approach this case?
So all of you agree that this is hypogonadotropic hypogonadism? So every child who is there will have hypogonadotropic hypogonadism. You understand that everybody who is young, LH-FSH will be low, you will say it's hypogonadotropic hypogonadism. So this is physiological. This is normal. Why unnecessarily we are giving, and this is very common. So you have to interpret levels as far as the various ages are concerned. If you do in this phase where the hormones are 0, you will of course have no levels which are there. So never do a workup before 14 years of age. This is very, very important.
Thank you, sir. We have this 12-year-old boy who presented with lethargy and weakness. His free T4 level was 3.2, which is low, and the TSH level of 12. Cortisol level was also low, and the ACTH level was 5.6. LH, FSH, and testo level all were low. So this picture is looking like MPHD to be. So, sir, what is your opinion in this case?
So yes, so what we need to understand is that you should always interpret the end organ hormone depending upon your pituitary level. So here you're seeing the TSH level is high. And everybody says if your TSH is high, this becomes a primary hypothyroidism. But you need to have a contextual assessment. So FT4 and TSH have a log linear relationship. If your FT4 level is low, TSH should be sky high. This is primary hypothyroidism. If you have got a high FT4, TSH should be 0. This is thyrotoxicosis. But if you have a high level of FT4 and a high level of TSH, this becomes a TSH adenoma, very rare scenario. So don't bother about that. But this is most important. A low FT4 and a TSH less than 20, always exclude central hypothyroidism before you treat. Otherwise, they will go into crisis in that perspective.
We have the 7-year-old girl who presented with tetany and muscle spasm. She had the hypocalcemia and a high phosphorus level with a normal creatinine level. And when the PTH level was done, it came out to be normal. So for me, I was expecting a low PTH level. So what could be the diagnosis in this case if the PTH level is not low?
So now first, if you look at hypocalcemia and hyperphosphatemia, normal creatinine, this is a PTH problem. Now, PTH should always be considered in the light of your calcium level. Here, the calcium is low, your PTH should be very, very high. So if your PTH is not high, we are thinking of an abnormal situation. So this is clearly a hypoparathyroidism, which you should be very, very cautious about.
So we have this 7-day boy admitted in an NICU, and we got a reference for his hyperglycemia. He was maintaining his glycemic levels with a GIR of 14 milligram per kg per minute. It was non-ketotic, and the cortisol level was 750. But this insulin level was 2 milli-unit per ml, and the insulin level is high for sugar.
So again, you need to have a contextual assessment. So this hypoglycemic child should have a zero insulin. Any insulin during hypoglycemia is significant. So in endocrinology, basically, as we discussed, you need to understand what assay you are doing, how you are recommending. You need to look for the pre-analytical issues in terms of how to write the assay, how to take the sample, when to take the sample, which lab to send, then which technique to follow. Look at the lab if you have a discrepant result, and always interpret in the context. What was the glucose when I did the insulin? What was the calcium when I did the PTH? What was the ketone level when I looked at insulin? What was the phosphorus when I did the PTH? All that becomes important.